Hi, everybody, and welcome. Thank you for joining us today for our next presentation in our TED Talk series. My name is Elizabeth Daly, and I am the Executive Director for the National Foundation of Swallowing Disorders. For those of you who have not previously joined our virtual events, please note that you will be muted throughout the presentation. We encourage you to ask questions at any point during the presentation using the question box in your GoToWebinar toolbar. There will be plenty of time reserved at the end of the presentation for your questions. This presentation will be recorded and made available on our website. We recognize that the international time differences make it challenging for some of our global audience to attend the live events. No ASHA CEUs will be awarded for this presentation. However, we are happy to provide a detailed certificate of participation. We would like to recognize and thank Bracco Diagnostics for their unrestricted educational grant that allows us to offer our TED Talk series free of charge, regardless of your NFOSD membership status. I also want to thank those of you who made a donation upon registering for this event or for our prior webinars. It's only with the financial support from our community that we are able to advance our mission. I would also like to take a moment to thank and recognize our educational sponsors, including SimpliThick, TrueAngle, Mira GTX, Cranio Rehab, and Passimir. And now it's my pleasure to introduce this evening's speaker. Please join me in welcoming Rinki Varindani Desai. Rinki is an accomplished medical speech-language pathologist, certified brain injury specialist, and dementia practitioner who is specialized in the assessment and treatment of swallowing disorders in adults. Her accomplishments span across all four pillars of the NFOSD's mission, targeting education, research, advocacy, and patient support. During her decade plus of clinical practice, Rinki has also become recognized for her educational initiatives, including co-founding the Swallowing Training and Education Portal, as well as founding an online educational SLP forum that reaches over 43,000 people around the globe. Rinki serves on the boards and committees for many professional organizations, including the ASHA Education Board, and is president-elect of the Mississippi Speech, Language, and Hearing Association. She also serves as a board member for a nonprofit for head and neck cancer survivors. And while these are only a portion of Rinki's contributions to the dysphagia community, I want to save time for her presentation and turn this over to her. So Rinki, thank you for volunteering your time this evening to present to our community. And if you give us just a few seconds here, we'll change presenter mode and I'll turn this over to you. Excellent. Yep, we can see your screen.
Okay, awesome. Let me just move myself out of the way so I can look at my screen, and then we should be ready to go.
That's good. Thank you.
Okay. Hi, everyone. My name is Rinki Varindani Desai. As Elizabeth said, I've been a long-time supporter of NFOSD's mission and have tried to do everything I can from an educational, clinical, leadership, and research perspective. And I think we're all here today because we're all sharing this mission of supporting individuals living with swallowing disorders and their families and caregivers. It's such an honor for me to just be part of anything that NFOSD does. So first of all, thank you to Ed, Elizabeth, and everybody at the foundation for all that you do to take this education and help clinicians and help patients living with dysphagia. Today, it's an honor for me to be part of this TED Talk series, and I'll be talking about how we can optimize our dysphagia assessments with instrumental exams. I also want to just mention a brief disclaimer that we were expecting a mixed audience, so people have different levels of expertise from basic to more advanced practitioners. So I will be covering a lot of information that might be adult dysphagia specific or more basic in nature, but I've also tried my best to incorporate free or affordable resources for advanced practitioners towards the end so that there's something for everyone. And I really hope you all find this talk valuable today. These are some of my disclosures, and I think Elizabeth did a great job of listing some of the things I'm involved in. So without further ado, let's just do a brief overview of why we need instrumental exams. It's unfortunate that we even need to discuss this because neurologists don't go around explaining why we need CTs and MRIs, and physical therapists don't have to justify why we need X-rays. But unfortunately, we still find ourselves in situations and settings where we have to justify to administrators and decision makers about why we need instrumental exams. We all know that our clinical assessment of swallowing starts with a clinical swallow evaluation, or a CSE, that can be a really, really important tool if leveraged correctly in helping us make hypotheses about why a patient might be presenting with dysphagia. But we also have evidence spanning over 15 years and 150 articles that tell us that the CSE is not enough. It cannot diagnose swallow pathophysiology or physiologic impairments in the pharynx that can help us make objective decisions about bolus flow. 40% of the variables clinicians say they're using in their CSE are not evidence-based. Less than 50% of the measures we typically use in our CSE exhibit adequate intra and inter-rater reliability. Our ability to detect aspiration using CSE is less than 70% accurate. And of course, if someone is silently aspirating, which, aspiration is not the be all and end all of our assessment, but if someone is, without demonstrating overt signs or symptoms of dysphagia, it can only be identified with the use of instrumental testing. So needless to say, instrumental swallow assessments help us visualize the structures of the upper aerodigestive tract, assess the underlying physiology of swallow structures. It helps us determine not just the presence, but also the severity and the cause of dysphagia. It helps us assess safety and efficiency of different bolus consistencies and volumes. We're now learning more and more that we're moving away from just penetration aspiration and also learning to assess bolus flow, timing measures, and kinematic swallowing measures using our instrumental assessments. We can use our time in the fluoro suite or while doing FEES to assess different compensatory and therapeutic strategies that can really help our patients and really help us make early and accurate diagnosis of swallowing disorders, which is key to minimizing complications and maximizing patient outcomes. That's kind of why I chose the title for our presentation today, saying we don't have X-ray vision. We can't treat what we cannot see. So the most commonly used types of instrumental exams, which hopefully everyone is pretty familiar with, are modified barium swallow studies or video fluoroscopic swallowing studies. Those terms are used interchangeably, or the fiber optic endoscopic evaluation of swallowing, or FEES. Again, I'm just going to provide a really brief overview of both of these in case someone hasn't had as much experience or is not familiar with them. So VFSS or MBSS is a radiographic procedure. It's typically done by an SLP in a fluoro suite, usually in conjunction with a radiologist or a radiology technician, where different types of food and liquid consistencies are mixed with barium and then given to the patient, so we can watch them in real time as the food moves from the mouth to the esophagus under video fluoroscopy. It's typically time limited because it does involve radiation exposure, but it really allows that direct dynamic visualization in lateral view, and also for those of us who do an esophageal sweep in AP view to really, like I said, assess the structures of the oral pharyngeal and upper esophageal structure and function. Again, for someone who may not be familiar with what this looks like on the other side, after we're done administering these different bolus consistencies, this is what a normal functional adult swallow looks like on a VFSS. You kind of want to see the different consistencies pass through really efficiently, fairly quickly. We're looking for things like residue. We're looking for how much effort the patient needed to swallow the bolus. We're looking for any kind of obstruction, penetration, aspiration, and we'll talk about that in future slides. So that's kind of what a normal swallow looks like. This is AP view on the left. And on the right, you have evidence of silent aspiration. So as you can see, this person had really poor airway protection. The laryngeal vestibule closure wasn't adequate, and the person had decreased sensation. So he aspirated the liquid and couldn't sense it as much, so had no reflex to kind of push it back out. So our two main goals for a VFSS or an MBSS is assessing bolus efficiency, how efficiently the patient can swallow without significant residue, effort, or repeat swallows, and airway protection. So is the person penetrating or aspirating, or can they protect their airway efficiently? So again, these are taken from the swallowing training and education portal that Elizabeth mentioned earlier. These are examples of what poor airway protection and poor bolus efficiency looks like. Both these swallows are disordered, but for different reasons. So the important thing to remember with an MBS is we're trying to identify, is this swallow normal, functional, or disordered? But the most important thing we need to identify is why. Is there an issue with airway protection? And what are the underlying physiologic impairments causing that, which will guide how we treat this patient? Is there an issue with bolus efficiency and movement, or is it a combination of both? So the most important thing I can stress for anyone doing swallow studies is that it is more than just the presence or absence of aspiration. Unfortunately, you're going to find yourself in situations even today where physicians don't know the difference. I will say a lot of SLPs don't know the difference. I am working with SLPs even today in more rural areas, or even people who've had training but not necessarily adequate exposure to the current evidence, where they will stop a swallow study if a patient aspirates, or patients are being put on feeding tubes and thickened liquids and deemed NPO, or are told not to eat anything by mouth just because of 1 or 2 aspiration events. But our time in the fluoro suite needs to be so much more than that. Otherwise, it's just a grave disservice to our patients. Our goal with the video fluoroscopy is to look at the structures, the different swallow events, and the bolus flow events that contribute to a safe and efficient swallow. And on the right, some of you might be familiar with the MBS-IMP, the Modified Barium Swallow Impairment Profile, developed by Dr. Bonnie Martin-Harris and her team, where they've really listed 17 different physiologic components that we need to be looking at when we're conducting these swallow studies. So some of the most significant strengths of a VFSS, it is the most comprehensive view of the anatomy and physiology of the swallow and visualizing the bolus from mouth to esophagus. It's widely practiced and accepted, has a large body of supporting literature. Like I said earlier, it allows us to really even test the effectiveness of different therapeutic strategies in the fluoro suite, and truly helps us identify the next steps in treatment planning by tying in evidence-based treatments with the underlying physiologic impairments. However, it does have limitations. So if somebody just has access to VFSS and goes in there and starts doing swallow studies, it doesn't mean we're doing the best that we can for our patients. Somebody who's not adequately trained, or somebody who's not following the same administration and analysis methods and is using techniques that may not be as standardized or may not be keeping up with the current evidence and research, are really kind of wasting the patient's time and resources. And that can quickly turn what is called an objective swallow study into something that's really, really subjective. So when we say things like reduced hyoid movement, noticed aspiration, recommending thickened liquids, all of those are just pretty subjective statements. So we need to make sure that when we're administering our swallow studies, analyzing them, applying them, it's always justified and based in solid and sound physiologic rationale. There are also issues with cost and access, because with an MBS, you need a radiology or a technician, you need a fluoro suite, you need expensive equipment, the patient has to be transported. Some people complain that it's also a very indirect and unnatural environment. You have this thing that's kind of blocking the patient's view. We're feeding them barium. It's limited by time because of radiation exposure. So it's just a snapshot of time and not truly a true representation of how the patient eats or drinks in a more natural environment. There are some technology limitations that we'll talk about later as well, in terms of the recording equipment we're using, the actual fluoroscopic machine we're using, and there can also be patient limitations. So somebody who's obese, somebody who has movement disorders, cognitive impairments, multiple medical comorbidities, maybe they're in the ICU and they can't be transported, will not be great candidates for an MBS. And I think one thing that COVID truly taught us is how to leverage the clinical swallow as best as we could, because of infection prevention, we couldn't transport a lot of these patients and get them access to swallow studies. So that was kind of everything about VFSS, and I'm going to quickly jump into FEES.
Ready for me?
This is a demonstration of a patient undergoing a FEES exam, where it's an endoscopic exam where a flexible endoscope is passed through the nose into the pharynx, and instead of the lateral or the AP view we saw in VFSS exams, we're getting the superior view of the pharyngeal and laryngeal structures as the patient, again, in real time is swallowing different food and liquid consistencies, and we're assessing their swallow. In a nutshell, on the right, as you can see, we truly get a great glimpse of the patient's anatomy of their pharyngeal and laryngeal structures like the tongue base, the epiglottis, arytenoids, piriform sinuses, vallicular spaces, and we can look for things like edema, masses, lesions, scarring, vocal fold function, and vocal fold paralysis. The passage of the food and liquids also helps us identify things like spillage before the swallow, residue after the swallow, and aspiration and penetration. So one of the biggest benefits of FEES is its portability. You can do it with trach and vent patients in the ICU. You can do it with patients who are bedbound in long-term care facilities. And since it doesn't really involve a radiologist and doesn't really involve a fluoro suite, it's just the SLP, and you can take your equipment and do it with whoever needs it. Again, it also provides, like I said, that direct visualization of more than just what a fluoroscopic image can show us, and really allows us to see vocal fold function in a way that we can't necessarily appreciate on fluoro. It's more cost effective, there's no radiation involved, it's not time bound, and it's more natural. There's no barium involved. You can kind of go as long as you want. You can watch people eat at different time points and really compare their swallows with different consistencies and at different times in the day. We also have some evidence to show that it has increased sensitivity to assess residue and secretion management, where on the right I've included images from a paper where you can see in the left-hand side FEES image, you can appreciate how pretty significantly severe that pooling of saliva and the bowl and the liquid consistency is, whereas on the right it kind of might look more like mild residue. However, again, like the VFSS, FEES does have some limitations. It doesn't allow for oral and esophageal phase visualization. So if a patient has something like a CP bar, Zenker's diverticulum, oral phase deficits that are not necessarily very obvious, or upper and lower esophageal phase deficits that are contributing to the dysphagia, we can miss a lot of that on a FEES. One of the other biggest limitations that have been pointed out in research and by clinicians who've had experience with both studies is this whiteout period. So at the moment of swallow, there's a whiteout period where you can't actually see what happened. Again, from the same paper, you can see where the VFSS indicated where these arrows are that the patient did in fact aspirate. It was a microaspiration event during the swallow. Nothing was visible on the FEES, so you might miss events like that. And really, like I said, not necessarily always have a clear picture of exactly what's causing their dysphagia that might impact treatment planning. There are some costs involved with the equipment with relation to FEES, and you also have to be aware more about policies and protocols for things like disinfection, how you bill for FEES. JACO and state have regulations with respect to how you disinfect the equipment, and there's other things like that that we need to be aware of a little bit more as compared to MBS studies. Now that was a quick overview of what these instrumental exams are, and today's topic is really talking about how we can optimize the use of instrumentals. So really we're doing justice by our patients and improving our dysphagia diagnostic accuracy as much as possible. So there are some key considerations and best practices that we need to be aware of that the latest evidence and years of clinical practice have shown us with respect to FEES and MBSS. With respect to FEES, I just want to dispel any myths that we're trying to pick a gold standard assessment or pick the better assessment. The assessment you pick has to be driven by the patient in front of you. It's a myth to think that we can we need to do an instrumental with everyone, or if we do a CSE and a FEES, we can't then do an MBS. There are patients who you might not need an instrumental at all because it won't change their treatment or outcomes. There are patients where you might start out with a FEES because they're in their ICU, or they might have to wait weeks or months before they can get a swallow study to start treatment planning, and then you might need an MBS down the road. So really you have to pick the assessment with respect to patient needs, your training, your comfort, access to resources and reimbursement, and so many other things. I'm also a big advocate of standing up for standardization. We have to stand up for standardization in the way we're assessing and administrating our instrumental exams including FEES and VFSS. And you need to get ready to start FEESing. You can't just get up and stick a scope down someone's nose. I'm sure you wouldn't want a healthcare provider doing that to you. So you need to go out and take some courses, get some hands-on training with learning how to pass a scope, learning the different policies and procedures. I found myself in situations in nursing homes where there were none. So sometimes you might be the first SLP having to create these policies and procedures. There are things that you have to follow in different clinics you might be in, where some people use topical nasal anesthetics to improve patient tolerance with these exams and to make it easier to pass the scope. And some people feel like it decreases sensation, so they stay away from it. There are also some people who are advocates of using blue dye, green dye, natural white dye, or substances to kind of help improve the accuracy of their FEES exams. And another thing to think about is residue rating. What might be mild for me might be severe for another clinician, and we really again need to make sure we're trying to make these exams as objective as possible, not just in terms of our training and administration, but also how we're analyzing, interpreting, and applying the findings of these exams to patient care. So I want to spend some time talking about that. You guys can take snapshots of anything that you might find useful, but like Elizabeth said, you'll also find a recording that you can go back to. I've included as many free resources as possible for somebody who might not be familiar with these. So on the left, you have VASES, a visual analysis of swallowing efficiency and safety scale. It's been developed by Dr. James Curtis and colleagues, and he has a website that I've listed that has free tutorials and training webinars. So thank you, James, for what VASES looks like. And it essentially is a scale that allows you to assess and rate pharyngeal residue penetration and aspiration in patients during FEES. On the right, you have the Yale Pharyngeal Residue Severity Rating Scale, where again, it just gives you a tool and some training to rate pharyngeal residue during FEES based on the location of the residue and the amount and severity of it. That again, it's still subjective. You're still rating things subjectively. You're not truly measuring anything, but it just gives you a way to compare pre and post swallows, pre and post therapy at different time points of the patient's care. And have some consistency, at least within your team, if there are multiple clinicians in the same facility, on how we are assessing and treating these swallows. And then finally, you have the digest, which is developed by Dr. Kate Hutchison, Heather Starmer, Susan Langmore, so lots of big famous researchers in the FEES world, where they're adapting the digest scale to FEES that allows us to assess pharyngeal severity, pharyngeal impairment severity during FEES in patients with head and neck cancer. These are two other resources that are free for ASHA members. I think the AJSLP article is still open access, so if you're not an ASHA member, you can still access that. For anyone starting FEES, if you want to learn how to standardize your FEES assessments and learn about best practices, please look at that paper called the Tutorial on Clinical Practice for Use of FEES. The one I've included is for adult populations, but they have one for peds as well. And then ASHA's practice portal has different templates for voice, for swallowing, for language. So I found that personally really helpful, especially when starting out with my students as well as a clinical supervisor, where they have these free templates for what a FEES exam should look like and what a VFSS should look like. It's in some places pretty extensive and comprehensive. You don't have to use all of it, but I think it gives you a good starting point of what you need to be looking out for when you're conducting these studies. Similarly with VFSS, we have to stand up for standardization. These best practices or key considerations revolve around how we're administrating our studies, what kind of technology we're using, how we're interpreting them and applying them. I have some considerations for documentation and communication. And then finally, I'd like to end with competency and training. So again, this is a free resource on Dr. Katrina Steele's website. She's a very well-known, globally renowned researcher in our field who's done some excellent work related to video fluoroscopy and put it all on her website, the Swallowing Rehabilitation Research Lab that I've listed here. This is all free. So they have an extensive table of VFSS best practice recommendations and really tell you how we can be standardizing things with respect to barium concentration, our stimulus consistencies, a lot of information about frame rate that we'll be talking about, how many swallows we need, how we're queuing our patients, what the different bolus consistency should be. So again, you don't have to follow all of this. It might differ based on your patient population, your team, sometimes with access and resources and kind of what you have available at your disposal. But I think for anyone starting out to do VFSS studies, this should be mandatory reading. On the right, we have two, again, free articles for ASHA members that I would highly recommend. The MBS for oropharyngeal dysphagia recommendations from an interdisciplinary panel and best practices in modified barium swallow studies. I make all of this, again, mandatory reading for my students, and I've found these articles to be really helpful. So I would really encourage you all to explore these and read more about this before you start doing your swallow studies. In terms of protocols and analysis, the most commonly used scale as such that kind of tried to standardize and make our studies a little bit more objective was the penetration aspiration scale. But it really looks for two things, right? Penetration and aspiration. So we've kind of moved away from that a little bit to the MBS IMP, which I think now is the most popular standardized protocol that's being used, which is still pretty subjective in my opinion, but at least it gives us a way to administer our studies and analyze our studies in a way that's more standardized and more consistent between clinicians and patients. I've also included information about the digest, which has been developed by Dr. Kate Hutchison and colleagues, which is being used increasingly to assess and rate swallow efficiency and safety in individuals with head and neck cancer during swallow studies. Dr. Steele has some information about the aspect C method. It's, in my experience, it's more commonly used in research, but she does have information about how you can use some of that and apply it to clinical practice for those who might be interested. And then on the website that I co-founded with Dr. Yanessa Humbert, we've dedicated an entire masterclass. It's called Masterclass Series Swallow Physiology. And in specific, I'd like to mention the video fluoroscopic interpretation of physiology, or the VIP training, where we have recorded courses and a practice portal where clinicians can actually sit and analyze different timing measures in a series of normal and abnormal swallows, and then learn how those findings can be applied to improving patient outcomes. I also want to talk about some technology considerations. So one of the important principles with VFSS is, again, radiation safety. I mentioned that before. You want to make sure the radiation is following the ALARA principle of being as low as reasonably achievable. But two other really important things that SLPs need to be aware of that, I'll be honest, I wasn't, and I kind of had to learn the hard way, is what kind of recording equipment we're using, if any, and what frame rate or what fluoroscopic rate the image is being sent at and collected at or recorded at. So on the right, you see an image of me with Dr. Yanessa Humbert, where we interviewed and had a conversation as part of a dysphagia grand round series we were doing with Dr. Heather Shaw-Bonilla, where she and her team have investigated the effect of pulse rate on judgments of swallowing impairment and treatment recommendations. And they found that when the frame rate or the recording rate or the rate at which the image was captured fell from 30 frames per second to 15 frames per second, aspiration events were actually missed, which significantly impacted the kind of recommendations we were making and ultimately affects patients' quality of life. So you want to use something like the TIMS medical system on the right, where you know the video is being recorded at 30 frames per second. You can go back and look at these videos, and you're not just having to make really quick decisions that significantly can alter a patient's life in the 4 minutes you have in a fluoro suite with everything else that's going on. And I also included another free resource, again, on Dr. Steele's website, where she has a lot of information about frame rate and some other technological considerations that really might be worth exploring and having a conversation with your radiology team, with the technicians, if you feel like those specifications are not being met. Because otherwise, even if you have all the training in the world and you're trying to do the best you can for your patients, if the equipment is failing you or the technology is failing you, we're really missing out on a lot of important information. I also wanted to include these 4 images from my place of work, the University of Mississippi Medical Center's Voice and Swallowing Center. So you have these 4 patients who kind of all presented very similarly on the clinical exam. They just had mild dysphagia complaints. We knew it was mostly pharyngeal, but when we took them to the fluoro suite, the underlying etiology or the cause of the dysphagia was completely different, which really changed the way we managed all of these patients. One of them had a CP bar. One of them just had mild residue post-COVID. One of them had a cervical osteophyte. And as you can see here, this patient had actual issues with sensation and airway protection post-stroke. So what this is, I've included this to show that the patient's symptoms should guide the assessment we pick. In most cases, you want to supplement a CSE with an instrumental assessment. That helps us find what the underlying impairment is. And once we've identified that, it should help us with our goal setting and our treatment. Sometimes the treatment might even be referring to GI or referring to an ENT, and the SLP just has to take a back seat. Sometimes you're the patient's biggest advocate, and you have to have a conversation with family or physicians to find the best possible treatment and management plan for that patient. So there's no clear-cut algorithm of what that would look like, but this is just to give you an overview of how our assessments need to be helping us find impairments that guide our treatment. 2 other big things that I'm personally a big advocate for are documentation and then education that we'll talk about. So again, you've done everything right. You have all the perfect tech in the world. You've done everything you can in the fluoro suite. But if we're not documenting things correctly with sound physiologic rationales and making sure those recommendations and our notes are reaching the next clinician who's actually treating the patient, if it's not us, we've kind of wasted the patient's time and resources. We have increasing evidence to show that a lot of hospital discharge summaries don't include our dysphagia recommendations. And I'll be honest, even in my own facility, I'll have physicians who just look at the radiologist note that just mentions penetration aspiration. If y'all were in front of me, I feel like I would see a lot of nodding heads, and they don't even take the time to read the SLP's note. So again, we have to be patient advocates and make sure our recommendations are reaching physicians and also being passed between care settings as patients move from the hospital to maybe more post-acute settings. This is an article written by Dr. Yanessa Humbert that I'd recommend everybody read in the ASHA Leader, where there's some tips included that help us improve our communication and documentation about VFSS and instrumental exams. We need to speak the same language, again, provide physiologic rationales, not just saw aspiration penetration and what our diet recommendation is. We need to share findings and strategies that worked for the patient in the instrumental exam. And it's also important, and I forget that too sometimes, is to mention the patient's strengths and not just their weaknesses and what they couldn't do in the fluoro suite. This is another topic that I'm extremely passionate about because I've been at a stage where in acute care, I had the best of everything. I never had to fight for a swallow study. I could roll my patient down to the fluoro suite whenever I wanted. But when I switched settings and moved into a long-term care setting in a nursing home where nobody before me had ever done a swallow study, I found myself in an extremely challenging situation as a clinician where I now had to justify why my patient needed an exam as obvious as an MBS or a FEES. That made perfect sense to me, but I had to build a case for instrumental swallowing assessments in long-term care. I wrote an article about it to help other SLPs that has, I've gotten great feedback about how that information has been really helpful. It's in the ASHA Leader, and there's a similar article on the right that mentions how we can speak the sniff lingo to show the need for instrumental assessments. So if anyone's in the same position as I was, please read these free articles and I hope it'll help you. What they essentially tell you is that we need to learn to talk the talk. We need to not get frustrated and upset when an administrator tells us that we cannot do something, be it a FEES, an MBS, something like vital stim. We need to learn to talk the talk in terms of their numbers, show them what the enormous costs and consequences of dysphagia is on a patient economically, emotionally, physically, how it's associated with higher inpatient costs, what rehospitalization means for them, what the cost of thickened liquids and feeding tubes are, and really focus on value and cost savings. That's what helped me. And once I had that conversation with administrators, I found that it was really easy for me to get access to these exams whenever I needed it. It also helps to identify local mobile FEES companies or mobile MBS companies that can come into your facility if they have issues with transporting the patients. It helps to build connections with SLPs in the community, and especially with social media now, we have webinars, we have Facebook groups, we have Instagram accounts where we can reach out to each other so easily, and you don't have to feel like you're isolated and fighting this battle alone. And again, just use current research and data to support your needs. So I included this in my article and I stand by this. It's important that we don't raise our voice, but we improve our arguments, and we need to be persistent. The last thing I kind of want to touch upon really quick is education, training, and competency. The bottom line is we need to do better. If we are clinicians practicing in the area of dysphagia, whether you're 1 year out of school or 20 years into practice, we have to constantly justify why we have the skills, training, and experience to earn this recognition as dysphagia specialists in healthcare settings. Unfortunately, the current evidence shows us that we have great variability in practice patterns across the world. We're seeing this since as early as 2003 to very recent articles even today. And I'd like to discuss 2 of them because I think it might be eye-opening for many. So Dr. Humbert and Plowman, they conducted a survey to examine practicing clinicians' understanding of something very simple. Can they look at a swallow and identify if it is normal or disordered? Very simple task, something we all do every day in our practice. And 188 SLPs practicing in the US were asked to make this binary judgment. This is what the swallow looked like. So do you think the swallow is normal or disordered? We had 46% saying it's normal, 54% saying it's disordered, and they were very sure that they would treat this individual. This is a healthy undergraduate CST student. So what they found that there was a very low level of agreement and consistency among SLPs and moderate to poor level of accuracy for classifying what a normal versus disordered swallow looked like. Dr. Vos and Humbert and colleagues further investigated what SLP's judgments of swallowing impairments are and whether they align with impairment thresholds available in the research literature. So 100 SLPs were presented with 3 MBS studies that ranged in complexity from easy to moderate to complex, and their task was to identify the most significant impairment that increased the risk of aspiration. This is an example of what the 3 swallows look like. They were played for these individuals, and as you can see, as it went from easy to maybe a little bit more complex physiologic impairment, the accuracy fell greatly. And what's really disappointing, or was hard for me to see as a clinician, is that it didn't matter if these SLPs had taken an MBS course, if they had done the MBS IMP training, or if they were both certified specialists in swallowing. In fact, the BCSS individuals did actually much poorly than the rest of the group. And they found that SLPs mislabeled 8 or more swallowing bolus parameters and physiologic impairments as disordered that fell within the normal range. That's a huge issue and a grave disservice to our patients. So all of these studies tell us that additional education and training in normal and disordered swallowing is absolutely and critically needed for us to improve our dysphagia diagnostic accuracy and really improve patient outcomes. So what I hope that I can share with you today is how important it is for us to do instrumental assessments, how important it is for us to infuse these best practices and key considerations when we're doing these studies. And here are some resources and takeaways that I hope will help you all in your practice as you return back to work tomorrow or on Monday morning. I've included free ASHA resources, at least for our clinicians in the US who are ASHA members. These are all free. So take your time to explore the ASHA practice portal, evidence maps, the journals that are free to all ASHA members, including some of the resources I included. If you're part of the SIG13 community, there are some great resources there as well. The FEES and VFSS templates I mentioned, and most facilities have their own competency frameworks that you need to check off before you can start doing these studies. We really should have mandatory competency frameworks, I think, by ASHA and by the state before we're ever licensed to touch our patients, but we don't. And we have increasing evidence to say that dysphagia graduate education and training isn't necessarily doing enough to prepare students to do these studies and to be dysphagia specialists upon graduation. So the SIG13 community, the SIG13 leadership community came up with the dysphagia competency verification tool. It has some guidelines that allow you to determine what skills you need to become competent in managing different aspects of dysphagia. So I think this is a good starting point for someone wanting to be more competent, or for teams to check off competencies for each other before you start doing these swallow studies. I've also included some reliable continuing education resources. I will highlight the word reliable because I want to kind of put this out there that today especially, it's really easy for someone to become a social media influencer, start a Facebook group, become an ASHA CEU provider, even if they have the money, and tell you that they're experts. And we live in a world where it's extremely easy to feign expertise, which is really frightening for me, especially when I have students come in listing some course that they've taken that promise them expertise or competency with VFSS or FEES, and then you go in and look at the course and it just isn't anywhere close to how detailed and thorough and comprehensive it needs to be. So we really need to all be better vetters of continuing education resources. And the ones I've listed here are resources that I trust, that I've had lots of clinicians around the world trust. The most common one being the MBS IMP training, which is available on Northern Speech Services, which I know now is being made mandatory for graduate coursework in a lot of universities across the US. I am the co-founder of the Swallowing Training and Education portal with Dr. Humbert, as I mentioned. Our mission has been to make swallowing training and education as affordable and accessible to everyone around the world as possible. We have extensive modules dedicated to normal swallowing, assessment treatment, MBS interpretation, and the swallow physiology masterclass that I mentioned earlier that you can explore on STEP community. I think it's absolutely critical that anyone trying to do FEES should take a FEES training course. They're available by several providers. The one I trained with is Dr. Langmore's FEES company, but you have many providers who will even come to your facility to help you get trained. And then you need to find someone local, I think, to help you with hands-on training, with passing the scope, and ideally someone in your team at your facility who's done this before to mentor and supervise you as you start seeing patients. The other two resources that I really like are ASHA Learning Pass. It is an extra fee, but they have an increasing number of courses now on instrumental exams. And when I started out, I used the 5-part series for best practices in VFSS on MedBridge by Dr. Katrina Steele that I really found helpful as well. And of course, as clinicians, it's really important that we infuse our clinical experiences, always keeping the patient at the center and the core of our management plans, but systematically improve our efforts to be better clinicians, colleagues, advocates, and investigators by infusing all of that and considering that against a background of the highest quality scientific evidence possible. There's too many clinicians out there who've kind of been doing the same thing over for 20 years, and Dr. Humbert has said this before, but you could have been doing the same thing wrong for 20 years, and that does not make you an expert. So there's no harm if a student of yours or a younger clinician maybe educates you about something you may not be aware of, and then you think about it and try to change your practices. There's nothing wrong in saying, well, I did something one way, but now the evidence tells me something else, so maybe I need to change the way I looked at dysphagia treatment, or I did exercises with my patients, or I thought about swallowing. So we need to constantly keep up with the evolving research. We need to constantly think about the patient's severity, their recovery, the social determinants of health in their environment, what kind of support they have at home, what their medical status is, and constantly weigh the risk versus the harm or the benefit of an intervention and evolve that based on patient needs. Here's some food for thought that I hope you can take away from the presentation today. Dysphagia is an important healthcare concern with enormous costs and consequences. I think we all are in a position of privilege. I think it's an honor for so many of us to help patients across the lifespan, from infants to geriatric individuals, eat and drink and swallow again. And it's such a blessing that we're able to do that, but we also need to realize that it comes with huge responsibility, and it's not something you can kind of just fake it till you make it. Because again, that's just a disservice to our patients and it's unethical. We need to be advocating for the use of instrumental assessments to identify the underlying cause of swallowing impairments, like I said, to determine safety, efficiency, and evidence-based treatment options. Different studies have different strengths and limitations, so we need to consider the patient factors, all the findings we talked about, your comfort level, your training and access to resources, and choose wisely. We need to follow best practice recommendations for exam administration, analysis, interpretation, documentation, and communication. And like I just mentioned, there's a critical need for SLP training, and just more effort across the board needs to be made for bridging the research practice gap. I hope that all of our therapy continues to be impairment driven, patient centered, so that we're all kind of working towards improving safety and function for our patients across all stages and all settings of their care. That image on the left is one of the Dysphagia Research Society meetings that I attended, where there was like a picture that said "Be the change," and I feel like I've really stuck by that my whole career, and I hope all of us can be change agents locally, at the state level, nationally, whatever it might be, to truly advocate for improving the lives of our patients with swallowing disorders and their families. Thank you so much for listening. I hope this was helpful. I have my email and my Instagram listed there if somebody needs to ask me any questions in case we can't get to everything today. And thanks again to the NFOSD for having me.
Hi, Rinki. Thank you so much for that presentation. I think whether you're a person living with dysphagia, a caregiver, a student, or an advanced clinician, I think we all got something out of that. And every time I see that study from Dr. Plowman and Humbert about SLPs rating those studies and about only 50% of them can rate it as abnormal or normal, it's always such a good reminder to me that we don't know everything and we can always keep learning. And it's startling too to think that perhaps you might be somebody who has a swallow study that's rated abnormal when really it's functional. We do have a good list of questions here, so I'll get started with that if that's okay. The first one that came in, I think, is a great question. How do you professionally ask the radiologist to continue the swallow study if they're trying to stop because there was an episode of aspiration?
I think it's obviously the obvious thing is just telling them to continue, but it's harder to have that conversation, I think, in the fluoro suite in the 4 or 5 minutes that you have in front of the patient and possibly a family member, sometimes even residents and techs. So I think it warrants and sets the stage for a longer discussion and really establishing that relationship between radiology teams and SLPs, where I think it starts with education. You have to be really professional and diplomatic in explaining to them kind of how far along MBS studies have come and how we're looking for things that are beyond aspiration, and maybe even giving them patient examples where the treatment changed because of the underlying impairment. One of those resources that I mentioned, the ASHA articles, I think it was published in AJSLP, where it says MBS recommendations from an interdisciplinary panel. There's a doctor in there, Dr. Sherry Cannon, who's done extensive work in working with SLPs, and they've come up with ABR recommendations, that's the American Board of Radiology, for how radiologists and SLPs need to be working together. And it has some good, I think, takeaway points that you can explore and read. But I think it just starts with education and being willing to kind of, sometimes it can be intimidating, but take that extra step to have those conversations.
Excellent, thank you. Another question here asking about the differences between the MBS-IMP protocol and Dr. Katrina Steele's recommendations for the number of swallows, saying that they kind of conflict with each other, wondering what your thoughts and recommendations are for the number of swallows for a VFSS.
I'm one of those clinicians personally where I take everything with a grain of salt where protocols are concerned, because a lot of them sometimes are done in research conditions that don't necessarily mimic real life. So I think for me, if our team has decided we're using the MBS-IMP protocol, that's kind of what I tend to follow. I think Dr. Steele's recommendations kind of do a good job of putting the research all in one place and saying this is what's out there. But she's also very clear about how these are just recommendations that help you be aware of some best practices that might change depending on the patient in front of you. I've never always followed one protocol for every patient. I'm one of those clinicians who kind of tend to see what the patient's needs are and let that drive my assessment. But I know some people who are sticklers for just following the protocol no matter what. So I think as long as you're doing the same thing between patients and your teams are kind of doing the same thing, ensuring there's some consistency and standardization, one way or the other would be okay. I don't think there's a right or wrong.
I have a question here from somebody who works in skilled nursing, wondering how we can do right by our patients when it's so hard to access instrumental studies, even with advocacy.
Yeah, I get that question all the time. I've been there, like I said, that I think you just need to be real, right? So I think the problem started with too many clinicians in generations before us. This is not to accuse anyone. I think they had difficult circumstances where they were kind of forced to say that they could detect aspiration at bedside. So one of the first questions I got is, well, if the clinician before you and the one before her all could detect aspiration, why are you asking for a $500, $1,000 exam? And that's what puts us in a difficult situation. But I think you need to be real and give those examples of CTs and MRIs and X-rays and just say, you know, if I don't have access to this information, it's the equivalent of an orthopedic surgeon saying, well, you know, maybe you should just have knee surgery that you might or may not need, or maybe you just need blood pressure medication, whereas you may or may not have a problem. That's kind of the equivalent analogy where we're saying, maybe we need to treat this patient swallow, maybe the treatment will work, but we have no way of knowing because we don't have access to an instrumental, and just leverage the clinical exam as best as you can, because some people don't even do that right. And then just being clear with your administrator, your supervisor, your colleagues saying, this is what I'm doing, but like I said, there could be more harm than good, hopefully will help people make more ethical decisions. But just read those articles that I have listed where you might find some resources that might help you change the conversation a little bit at your facility.
Thank you. Another question here asking if you can comment on assessing competencies for performing what's considered a designated act. So for example, in Ontario, there's a physician that has to designate you to do a FEES because it involves inserting the scope in an orifice. So I'm wondering if you can comment on how you assess those competencies.
I haven't personally been at a facility where I've had to do that, but I know in India, for the longest time where I'm from, only ENTs could pass the scope. And where I practice now in Mississippi, there's certain insurances that like if they're from the VA or they're from a certain private insurance, only my physician can bill for it. Like I said with fees, that is one of the limitations where you're restricted to whatever policies or regulations your community or your state or your country mandate. If that's kind of how if that's the only way you can pass a scope and get trained or competent, I think you just kind of have to follow the way it's always been done. I hope that's helpful. I mean, I don't know if there's a way around it. You kind of just have to go through the process, I guess, and get trained and deemed competent, and then start doing your FEES exams.
Does ASHA, you may have mentioned this, does ASHA have protocols for assessing competencies for either exam?
No, and they really should. And we've pushed for this a lot. As you know, states license us in the United States, so every state is different. The state of Tennessee now has a FEES competency requirement, which is great. I think they're setting the stage for something that needs to change. All that ASHA has put out is that DCVT tool. It's called the Dysphagia Competency Verification Tool. It's just a template. You don't have to use it. It's not necessary, but I really think we need to be in a place where nobody should be allowed to do these exams if we haven't gone through some kind of standardized competency or training.
Yes. And for the patients on the call, the people living with dysphagia and their caregivers, how can they be sure that when they go in for their swallow study that they've waited perhaps months to get, that they're having the study done by somebody who is competent in doing these?
You would hope. I mean, I'd like to believe that all of us are in this profession because we want to help our patients and we go into work wanting to do the right thing and wanting to be ethical. So I think most people I talk to have taken that step of going above and beyond and getting trained in some way or form, and they're not just doing swallow studies just because. It's the same as going to a doctor, right? Like you have credentials you can look at, but as we saw in the research, the credentials don't necessarily always demonstrate competence. You just have to kind of have trust. I think it's okay to have conversations with your provider, asking them if they're comfortable with this, how much experience they have, and asking those kinds of questions. But I think it ultimately just comes down to trust and hoping that clinicians are doing the right thing before they start seeing patients.
And along those lines, would you encourage people with dysphagia to question their providers, and not necessarily in a confrontational manner, but just to ask questions in real time about the results?
Absolutely. I think all of us as patients would want that for ourselves, right? Whatever provider you're working with. I do find that, again, in the United States, coming from a different country, I do feel like there tends to be more trust in providers and healthcare recommendations, and I don't get asked questions a lot. Whereas in India, it was really common for me to be questioned about everything, or for me and my family to question the provider about everything, get a second opinion. Obviously, reimbursement limits how many providers we can see for the same thing. A lot of patients don't have access to the financial resources. They're stuck with one provider in their community and they can't travel hours to go see someone else. But I think it's completely okay, and I would encourage patients to have those conversations with their providers, especially if the recommendations being made involve putting you on any kind of modified diet, on something like thickened liquids, saying your loved one needs a feeding tube or you need a feeding tube, especially for things like that that are significantly taking away the pleasure of eating or drinking. I do think those conversations are warranted versus just accepting whatever is being told to you.
Thank you. I know you specialize with adults, but I have a peds question here for you. Do you know of any good training programs for FEES for pediatrics offhand?
Honestly, I'm not a peds specialist, so if I'm missing something, I greatly apologize. I just haven't kept up with the pediatric world as much. I did work in Dallas for a few years, so I know Baylor University Medical Center, BUMC, has FEES training courses that I've had some colleagues go to, and they do that a lot once a year at the beginning of the year, I think. So I think if you looked up BUMC and FEES, I'm forgetting the name of the trainer, but that should come up. I'm trying to think if I can think of something else. I think Carolina Speech Pathology has some courses online about it, but I don't know of any other training programs off the top of my head. I'm sorry.
No worries. And if the person who asked that question has more questions about that, the foundation has a medical advisory board with 2 pediatric specialists, and I'm happy to pass that question along to them for more information too. A couple more here, Rinki. Just we're getting to the top of the hour, so I want to be mindful of our time. But one question that I have here, is there ever a time where it's not appropriate to push for an instrumental swallow evaluation?
Yes, and I feel like I can dedicate a whole webinar to that because that's really important. Like I said, it's a myth to think everybody needs one. As I said in my talk earlier, if it doesn't change the patient's outcome, you wouldn't do it. If a patient isn't appropriate for a swallow study, for medical reasons, you wouldn't do it. But I've had a lot of patients, especially in working in nursing homes, where they've just said, you know what, I'm going to live with my dysphagia. I want to eat what I want to eat. I want to drink what I want to drink. I'm already dying with, be it stroke, COPD, dementia, whatever it might be. And they've made that decision for themselves that doing an instrumental wouldn't necessarily change their treatment plan or their diet or whatever it is. You're having that, the reason for doing the swallow study wouldn't change the outcomes. In that case, you wouldn't do it. So it really is dependent on, like I said, the patient's wishes, their readiness for a swallow study. You might have to wait a while sometimes to do it. With some of my patients with ALS, like a disease like ALS that I know is degenerative in nature, you might just do one at the onset where you know a feeding tube is coming down the road, if that's what they choose, and then I wouldn't waste their time repeating a swallow study again and again. So those are some examples of where the diagnosis or the patient's wishes would dictate whether you do one or not.
Excellent, thank you. Another question here. From the beginning of your presentation, you said that you sometimes will use the swallow study to assess effort and more subjective aspects of the swallow too. And how do you measure that or describe that, I guess? So effort specifically.
All specifically mentioning that. So unless I said something else and it was misconstrued, like I know we talked about bolus safety and efficiency, so how effortful the swallow was. But in terms of an instrumental, what that looks like is residue. So I think I showed you some examples of bolus efficiency where there could be no penetration or aspiration, which is what a lot of clinicians tend to focus on. But you'll see a significant residue on the study, or you'll see secretion management issues on a FEES. That's what effort looks like to me. And so that tells you there's a weakness problem or a strength problem more than a timing issue or something like airway invasion being compromised, and then your training and exercises would be more strength-based to try to improve that weakness.
Excellent. And then last question here to kind of wrap things up. In your report, do you comment on, so obviously if you're the clinician giving the swallow study or the FEES exam, comment on the person's behavior. So let's say, for example, that the video swallow study showed a safe swallow using some sort of maneuver or strategy, but it took that person minutes to understand how to do that, and there's no carryover where you have to train that each time. Is that something that you would comment on in the report, or how would you explain that to the clinician following up with that patient?
Absolutely. So I always tell my students, especially after I started getting students, you think so much more about how you're practicing. And I always tell them we're dysphagia specialists because someone decided to call us that, but we're speech language pathologists. And in the real world, you don't have dysphagia separated from aphasia, separate from cognition, separated from voice. So when the patient is in front of you, we automatically have to put our SLP hat on. And even though they're there for swallowing, we're looking for everything else. We're assessing how their receptive and expressive language is, what their cognition is like. I've often found voice problems or fluency issues that might suggest a neurological impairment that warrants a neurology referral. So you're kind of thinking about all of that, because obviously if someone can't follow commands or is having some cognitive concerns where there won't be carryover, it's going to impact treatment greatly. So I feel like that's almost equally, if not more important than commenting on what we see subjectively or the objective things we're seeing in an instrumental. You absolutely need to comment on everything that the patient is presenting with.
Excellent. Thank you. Thank you for answering all those questions. We received a lot of questions, so if we missed yours and you have if you have a different question that we haven't had a chance to answer, please feel free to email us. You're welcome to email Rinki directly, or you can reach us at info@nfosd.com and we will pass those questions along. And with that, we'll wrap things up. Rinki, I want to thank you so much for volunteering your time and your expertise to present again to our community. It's very much appreciated. Thank you, everybody, for joining us. Our next presentation will be on July 26th. It's one of our Meet the Makers presentations. And Dr. Kristen King from Passy Muir will be here to talk a little bit more about tracheostomies and the role of a speaking valve in speech and swallowing. So you're welcome to join us for that. I will be sending out an email momentarily that includes a post-webinar survey that takes less than 3 minutes. It's I think 4 questions, anonymous. We would really appreciate your feedback on that, and we hope to see you later this month for our next webinar. All right, thank you again, Rinki. Take care.
Have a good week.